So we're going to review, the learning objectives are up there and I don't need to read them out, but we're going to talk about what's new and different in the diagnosis and treatment of RA, and what about where are we really going in future directions. And again, I have a tremendous thanks to Paul for starting this off. So I'm going to have four basic vectors here. The first vector is initiating therapy. Then we'll talk about relaxing therapy, which Dr. Emery mentioned, and because this is also subsequently a webcast, I'm going to have a brief review of his paper. Changing therapy, and finally safety, which is, there's been some very interesting new issues that were presented at the ACR meeting in Boston. Okay. So here are the poor prognostic factors for rheumatoid arthritis. Okay, you can all look at this: seropositivity, erosions, duration, smoking, poor functional status. But really one that's been a controversial area and one that's really been poorly defined is the whole concept of body mass index. And I'd like to talk about obesity. So this is a trial which was presented as a poster at the American College of Rheumatology meeting in 2014. And this is the CATCH cohort from Canada, which is the early arthritis cohort. And they took 944 patients on whom they had 3 years of follow-up, and they measured their likelihood of being in remission as a function of their BMI, okay? And the incidence of remission in their optimal BMI was 18.5 to 25. So what's shown here is the odds ratio of being in remission relative to that group if you had a BMI greater than 40 or less than 18.5, 25 to 30, and so forth. So for example, if you had a BMI of less than 18.5, your chances of being in remission were 55% of the chances that you would be in remission if you had an ideal body weight. If you look at BMIs from 25 to 30 and 30 to 35, there's not much difference. But when you get to 35, a BMI of 35 to 40, and I know many of you have patients like this in your office, or a BMI of greater than 40, you can see that the incidence of remission is much, much lower. 50% or even 2/3 reduction in remission. And I think this is something, I don't know if anybody's seen this in their practice. I've certainly seen this in my practice. Patients who lose weight feel better. The disease becomes remits, and becomes much easier to control. Now, just so if you didn't believe me, here's a retrospective study from the Brigham and Women's Hospital where they took 53 patients with rheumatoid arthritis who had a mean BMI of 47 undergoing bariatric surgery. Now, the mean weight loss was 90 pounds at 12 months, so the surgery was effective. Of the group that went into the surgery, there were 29% that were in remission, and at 6 months that went to 72%, and 12 months at 68%. And this was without a change in therapy. If the low disease activity fraction was 43% at time 0, you obviously didn't want to send somebody in a really active flare to surgery, but it went to 85% at 12 months. I'm just looking around, I think this is something, I know you all have seen this. I would really, has anybody not seen this? Good. Nobody's seen people gain weight and then going into remission. In fact, that's obviously one of the problems of our therapies. So when we still see that patient for the first time, how many people don't start with methotrexate in a seropositive rheumatoid arthritis? Please raise your hand. How many people don't use methotrexate as first-line therapy? Okay, 1. Okay. How many people use triple therapy as first-line therapy? Okay. So let's talk about what the literature is on this and where the most recent studies have taken us. The CAMERA 2 trial was a study that came from the Netherlands, and they showed that if you use prednisone 10 milligrams a day in the first 2 years, you reduce the need for biologics from 41% to 15%. This is with optimizing the methotrexate dose. And the references are in the bottom right-hand corner. The triple therapy versus methotrexate trial in TIER was not looking at biologic need. They were looking at low disease activity. And they found that methotrexate at 6 months and even 48 weeks was inferior to triple therapy. Now, fortunately, if you move somebody after 24 weeks to triple therapy from methotrexate alone, you would get yourself in a 40 to 45 degree low disease activity state. So you didn't really lose a lot. So the Dutch investigators, so this is the first European study of triple therapy since SWIFOT, and I believe this has been submitted for publication. They used, they called it the T-REACH study, and they had 281 patients with early RA, and they looked at triple therapy versus methotrexate. Now, this is the best data that's out there. It's the newest data that's out there. But I want to point out some things. The mean disease activity, mean DAS, was not that high in this patient population. It was 3.3. And the mean DAS at 24 months was 1.66. So they halved the DAS. They put them in a DAS remission in terms of the mean. But again, they didn't start off that active. What I want you to know is that there was no difference between methotrexate and triple therapy in terms of achieving a DAS remission in this patient population. What was interesting and a little bit surprising was that the delta HAC, the amount that the HAC changed, was much greater in the patients that were on triple therapy versus methotrexate. Not something we typically think about, the HAC. And the percentage of patients that went on to biologics was also markedly reduced by triple therapy. Triple therapy, only 24% went on to biologics, whereas 43% of the patients with on methotrexate alone went on to biologics at 2 years. So again, I think triple therapy continues to sort of assert itself as being an effective trial. I don't think all of us are, most of us are starting using it as a second line to our patients that are not optimally controlled with methotrexate, but there is certainly data that suggests it should be first line. Okay. The next topic I'm going to talk about is relaxing therapy, and again, I was unaware of Dr. Emery's presentation, but actually it makes what is a difficult study much easier for me to summarize. And I'm going to talk about 3 studies: PRISE, AVERT, and PRESERVE. Now, PRESERVE, I just want to remind everybody, was a study that was done in Europe where they have the etanercept dose in patients that were in low disease activity, okay? And they were on background methotrexate, and they were in a methotrexate inadequate responder population. And in that trial, if you have the dose of etanercept, much like Dr. Emery was talking about, you maintain a high level of remission. Okay, so here's the PRISE study. You've just seen this. I don't need to review it too much for you. Instead, I'm going to go to this slide, the phase 1, phase 2, and phase 3 data. Now, this is in contrast to what Dr. Emery was talking about when he was talking about Boolean remission and HACs. And the absolute remission rates are shown here at the end of the phase 2 period. It was 63%. Remember, at 52 weeks, everybody was in remission. That's how you got into the trial. One arm went on to half-dose etanercept. 63% stayed in remission at 91 weeks. The second group was kept on methotrexate. 40% remained in remission. And the third arm went to placebo, and 23% remained in remission. If you then stopped all the therapy in all 3 groups, the remission rates were 44% with etanercept, so now nobody's on any therapy. The group that was randomized to methotrexate alone, 29% stayed in remission. And the group that was on had been on no therapy since week 52, the placebo arm, was 23% remission. And what was interesting is that if you went to the placebo arm, it looked like you didn't flare anymore, have a larger flare between week 52 and week 91, and then from week 91 to 117. Now, the companion trial to this is the AVERT trial. The AVERT trial was also trying to do the same thing. It was not working with as many patients with early disease, or that the definition of early disease was less than 2 years, which is more elastic than is typically seen these days. Although early in my training, this was considered very early disease. So they took 351 patients, and they did not have a placebo arm. They randomized patients to methotrexate alone, abatacept, 125 milligrams sub-Q a week alone, or methotrexate and abatacept for 1 year. And then they took the patients that were in low disease activity, and they basically stopped treatment, okay? And at 12 months, the remission rates were really quite good. I think and this all points to this concept of relaxing therapy that Dr. Emery was talking about. Even in groups that went to placebo, a significant percentage stayed in remission off of everything. This group saw 61% of the patients who had been on combined biologic and methotrexate stayed in remission at 12 months. And it was 45% to 45% and 42.5% in the other two arms. So again, making us all believe or all suggest that there's room to stop therapy. And then the most interesting thing is that some patients, if you went out 18 months, you then, which is actually a longer term of follow-up on placebo, you started seeing the remission frequencies really started dropping. That is, a lot of people started relapsing. This brings up the question that Dr. Tesser asked Dr. Emery, does this lead to, can you still recapture these patients and put them in remission? Actually, in my own practice, this is something I've seen in patients who've been absolutely controlled on methotrexate for 15 or 20 years, and I stopped the methotrexate. And many times it's at 18 or 24 months that they come back and see me. So actually, this fit in with my own clinical experience. Some people flare early, but some people really flare late. Okay, so when we talk about this, we have to remember that there's two basic categories here. One is induction therapy of new onset RA, and that is not likely going to happen with biologics unless something changes with our payers, or it's shown to be absolutely unambiguously cost effective. But it really establishes that drug-free remission is possible. The open question is whether, if somebody flares, can remission be reinstituted easily. In the methotrexate inadequate responders, it's very clear that once you put them into remission on a TNF antagonist, you can relax the therapy. But the question really is how relevant are these to the way we practice? What's a real-world strategy to how we can perhaps relax therapy? And that's what I want to bring up is the DRESS trial. This is a plenary presentation at the American College of Rheumatology. Again, coming from that great clinical lab in Europe that's known as the Netherlands. That's a joke, sorry. Okay. So they took 121 patients and that had failed methotrexate or failed some therapies and were now on a biologic, and they were on either etanercept or adalimumab. And what they did, now some of these patients were on monotherapy, as I'll allude to in a second. That is, they were so well controlled, they didn't need any background methotrexate. Every 3 months, they tapered the TNF, and they had a protocol for tapering the TNF. If you're on adalimumab, you went to Q3-week dosing, then Q4 weeks after the next 3 months, and then if you were out 6 months through 2 taperings, you then it would be stopped. With etanercept, they went to Q10-day dosing, then Q14 days, and then stopped. Now, if you had a flare, like a minor flare, that is the DAS28 went above 3.2, they would give you a shot of IM triamcinolone. The Europeans love doing this, and then they would bring you back in a month. If you were still active in a flare with a DAS over 3.2, you were considered a failure of tapering, and you were not retapered, okay? And what they did is they compared this in their 62 patients against 59 patients who were also in remission, matched perfectly, but actually a higher frequency than were on background methotrexate, 69% in this group. So they're on background therapy with methotrexate and a TNF antagonist versus a group that's getting their TNF antagonist tapered. So what happened? Well, there was the primary outcome. There was no difference. There was no difference in major flares. Remember, the primary outcome is major flares. That is the failure of tapering. And what was fascinating in their 2-year follow-up is that it was no difference. That is, and this is not surprising to us. We all know that some of our patients that are in remission on a TNF antagonist fall out of remission. But the other outcomes that were, but it was no difference in whether the TNF was being tapered or not in terms of total outcomes. There was no difference in the overall median HAC, quality of life, DAS28, or X-rays. There, of course, were many more minor flares, those flares when the dose is adjusted and the patient had to get one dose of IM corticosteroids. That was 73% in the tapering arm versus 27%, which is interesting because I think when I taper, when I try to go to every 3 weeks, adalimumab, for example, and I'm sure many of you have done this, is that if the patient tells you they flare, you kind of say, okay, that didn't work, and you back off. But maybe we should push a little bit harder and try to temporize a little bit. But at 18 months, 43% of their tapered arm were on reduced dose, and 20% were off the TNF antagonists. And so the cost savings on this was $7,500 per patient per year. So think about this in the affordable accountable care organizations that we all may confront in our future. What about changing therapy? So in the methotrexate inadequate responder, we almost always talk about TNF, but there's obvious efficacy in many agents. And here they are. They're all approved. And we have new agents that are coming around, and this is the landscape. And we have JAK inhibitors, we have biosimilars, we have co-stimulatory blockade, there's new co-stimulatory blockers that are being developed, and so forth. So the question I have for all of us is what's going to be choices that we're going to make or going to be made by the payers, okay? Well, obviously, if there's morbidity, so if you have a patient who's failed methotrexate and they have a history of MS or a history of lymphoma or something like that, you might be a little quicker to reach for rituximab, which has activity in those diseases. So morbidity may drive choice. But the question I have for all of us to think about is, are we all basically stuck with the paradigm that if you're methotrexate inadequate responder, you get a TNF antagonist, and then if that doesn't work, you go for a change in the mechanism of action? And as Dr. Emery was referring to, are there biomarkers or sort of blood markers that can predict this? This is obviously not something you can use a power Doppler to tell you what they're going to respond to in the future. So what I want to I want to mention a trial a paper that came out in March of this year in Arthritis Research and Therapeutics. And some of you probably are not, most of you are probably not aware of this because this comes into the more translational readership. So what I want you to I'm going to summarize a lot of data, and what I want you to just think about is that a group that's an industry-based group and the University of Michigan, that is Roche and University of Michigan, analyzed synovia from patients with rheumatoid arthritis. And they found that certain genes are upregulated in some patients with rheumatoid arthritis and some genes are not. And that they found that there was variable regulation. So they analyzed the top 40% of variable genes that were expressed in the synovium. And they said, what's different about these? And what are the genes that go up while the other ones go down and so forth? And they came down to, they found two basic genes that they were interested in that had peripheral blood equivalents, serologic markers that reflected what was going on in the synovium. One is soluble ICAM1, and one is CXCL13, okay? It's not really important what their biologic roles are. What is important is that they predict clinical response. So let me take you through the trial. ADACTA was a trial where tocilizumab and adalimumab as monotherapy have a duel, right? Does everybody remember this trial? It came out a few years ago. And as you may recall, tocilizumab had an ACR 50 of 47% in its overall, and adalimumab had an ACR 50 of about 28%. If you looked at those two, you group the patients in those with those biomarkers in this trial. So you looked at the patients on the far left-hand column along the y-axis who had high soluble ICAM1s and low CXCL13s. The frequency of ACR 50 in that group for adalimumab was 42%, whereas only 13% with tocilizumab. So kind of a clear win for adalimumab, 3 times likely to do an ACR 50. If, however, you went to, 42% versus 20%. If, however, you had a high CXCL13, which is actually a B-cell cytokine, B-cell marker, B-cell activity marker, and a low-soluble ICAM-1, which is made by monocytes and macrophages. Tocilizumab won very strongly over adalimumab. Okay, five-fold difference. So one of the questions that I think all the companies and all pharma and most of us are really interested in is what can we do with this information, and will this be present and guide further therapies, so that if you do have somebody who's a methotrexate inadequate responder, you don't just reach necessarily for the TNF of choice or the biosimilar of choice. I'm going to close with safety. So, we spend a lot of time on safety. I know Lenny's going to talk about it. I'm just going to briefly summarize my impression and my review of the literature in 2014. And I just want you to know there was about, if you type in safety and biologics in our rheumatoid arthritis, there's about 700 papers in the first 6 months of 2014. So this is not, if you want to quote something to me that I've never heard of, you can do it. But what I do want to point out is that randomized controlled clinical trials, long-term extension studies done by the pharmacies, registry studies, those, quote, real-world studies that are done in various Corona, Europe, and so forth, database reviews, where you go to the United Healthcare database and you type in rituximab and hospital admission and rheumatoid arthritis, and the Cochrane database, which is a review of all the world's literature. The hazard ratio for the relative risk of serious infection is really pretty modest. And it's somewhere between 1 and 3%, 1 and 5%. But if you think about that, the absolute change over the baseline is really quite trivial. And I think that's most of our experience. Now, there are people you put on a TNF antagonist or some other agent, and they get a lot of infections, and we all know about those. But that's not going to be a major driver in what agents we choose. But what about cancer and TNF inhibitors? Remember, this was a big paper by Bongartz. It caused a lot of controversy, talked about increased risk of various skin cancers, other cancers. And I went to a symposium at the ACR meeting, and it was just astonishing. International group after international group after international group got up and reported on their data about TNF inhibitors in cancer. So the Swedish nationwide registry talked about the whole, in all of Sweden, 12 or 15 million people, the squamous cell cancer index frequency. It was 2 times higher in your rheumatoid arthritis population than it was in your control population. With a TNF, if those patients were on a TNF inhibitor, it was 2.2 times higher. So there's only a 20% increase. Basal cell cancer increased slightly, 20% with rheumatoid arthritis. Absolutely no association with TNF inhibitors. Now, I don't know about you, but I must have said it 100 times that there's, based on the previous literature, that basal cell cancers are increased in my patients when I put them on TNF antagonists. Well, I'm not going to do that anymore. Korea talked about from their registry data, people following their solid tumors, solid tumor diagnosis. Sometimes within a year or 2, 12 to 18 months of recent treatment, they're still putting them back on TNF inhibitors. They saw no increased risk of recurrence. And with regard to the patients that were on rheumatoid arthritis, had a solid tumor, and then never got started on a biologic. Denmark showed for those young women with cervical precancer lesions, no effect on cervical cancer progression. And finally, from a large multinational study in Europe, there was no increase in invasive melanoma with TNF antagonists. That's pretty amazing. And that's pretty good data. And all these things were presented at the ACR meeting, so they're all going to be coming out in the literature in 2015, I expect. So my take-home points today are initiating therapy, attention to weight and smoking, limiting progression to biologics is still the challenge, but we've talked about relaxing therapy and the possibilities of cost savings. I mentioned a preliminary, the first really solid data about biomarkers actually changing the equation of therapy and which agents you use, and I think we're going to hear more about that especially with CXCL13 and soluble ICAM-1, I think, in the next year or 2. And safety, I would really offer that I think many of my prior safety concerns have been diminished by the continued evolution of the literature. Thank you very much.
As you know, the abstracts have just really grown in this field, and it's really difficult now to encompass all of cardiovascular. But I thought I'd highlight some things, some comorbidities in RA that I thought were interesting. The first one that I'm going to review comes from the Nurses' Health Study. We've had many different avenues looking at this large epi studies. It started in 1976. There's 2 parts to it. They followed over 120,000 nurses over this period of time, and they have been assessing many different factors, looking at many different predictors. At this particular meeting, they looked at the nurses with RA and those that did not develop RA. They found 960 RA cases in this population, and they were looking at mortality, and they found 260 deaths in the RA cohort, or 27%. And what was really interesting is, many of it is what you predicted from cancer, cardiovascular disease, and respiratory causes. But when you compare them to controls is when we found a very interesting comparison. So when you look at just all-cause mortality, women with RA did have an increase compared to controls. The increase was definitely higher in patients that were seropositive, so many of the things that we would have gathered compared to seronegative RA. And every 5 years of duration, they found it conferred an additional 32% risk compared to the non-RA cohort. And what was really interesting is when you really broke down these different increased risks of mortality. So if you look at cardiovascular disease, as we all know, the hazard ratio is 1.87. Cancer was a little bit lower at 1.35, but respiratory disease is really what popped out. So in this particular study, it showed that the hazard ratio was quadrupled compared to the other things that we are commonly seen. And in the seropositive RA cohort, the hazard ratio was above 6. And so this study reports that there is generally an overall increase in mortality in women with RA compared to non-RA women, but respiratory failure is really something that really popped out and I thought was very interesting, and whether or not this might change the way that we think about our women in RA practice. So we can talk about that a little bit later in the Q&A section, but I thought this was sort of interesting to highlight, even though we understand and accept the increased mortality at times, the question is, what do they really die of? So as you know, in cardiovascular disease, we have a lot of expensive testing, and we also do a lot of screening. So I thought I'd pick both of these areas to briefly go over. So this is a new sort of PET MRI imaging that's come out. It doesn't have as much of the radiation exposure as you see from some of the other CT or multi-detector CTs that are looking at the coronary tree. This particular modality I think I find really interesting, looking at the FDG PET. What they were looking at is actually carotid inflammation, and this one looked really at the plaque content and really uptake at the plaque content, which gives us a little bit more detail to how these cardiovascular risks in our patients can occur. So they're looking specifically at T1 weighted sequences from the MRI. And they demonstrate that there is, here's a picture of a RA patient that has some increased uptake in a carotid artery plaque in an RA patient. Many of the problems that they have between MR and CT is really resolution. So trying to decrease some of the CT slices with overlapping MR images can really allow this modality perhaps maybe to do in more serial ways, where in certain other CT-only images we might be limited due to exposure. So what this found, they just took a small cohort of 12 RA patients, and they measured any inflammation in the carotid plaque. And what they were really trying to look at was whether or not disease activity could affect the inflammatory changes that would be occurring, and if there's a way that we could really link some of the mechanisms between what was actually happening in an RA patient and what was happening in their vasculature. So in this particular study, they found a mean thickness of 2.5 millimeters with less than 70% stenosis. And the significant for that is that many of us might run sort of your carotid studies that we do for screening, and many of these patients would not have the stenosis that we might think about that would trigger further cardiovascular evaluation and treatment in primary prevention, but looking at plaque inflammation might give us clues as to people earlier on that might be at risk for more cardiac damage. So this study showed that although there was a majority had carotid plaque vascular inflammation in patients that were active, they did not really were able to correlate your disease activity score with the subclinical plaque formation. So they saw that there was some increase, but they couldn't really, maybe because either the study was small or maybe this was not the exact modality that could distinguish in terms of disease activity. However, in a similar study done in the Netherlands, they also looked at this new technology, FDG PET, and they looked at a small cohort of RA patients active, a little bit larger than the other one, 29, but then they compared it against controls, osteoarthritis controls, and they did a similar analysis with CRP and DOS, and this particular study showed that not only did the RA patients have more large vessel vascular inflammation by FDG PET, but it also correlated that patients with active RA had more plaque inflammation than those with OA and other low disease activity with RA. So this might be a modality that we could use to hopefully be a little bit more specific in looking at our patients with cardiovascular risk. So the other area that I'm really interested is that now that we have all these fancy tests, are we screening, or how do we screen for patients? I was just wondering by a show of hands if the rheumatologists in the room here routinely screen their RA patients for any of the RA cardiovascular risk factors. So I see maybe 8 hands routinely who screen. And so what does that even mean? So what do we screen for when we say we screen? So I'm going to bring some of the abstracts that I saw during the meeting that looked at this particular topic. So do you think that it's the rheumatologist's responsibility, the primary care responsibility? And so I have a couple abstracts that I'm going to go through rather fast, but just I thought were interesting. There was many looking at screening. So this really encompassed a lot of areas and all different over all the parts of the world. So just to recap, that we know that cardiovascular risk has been elevated in all of the systemic rheumatic diseases, and they're independent of any of the traditional risk factors that we might think of. The most commonly used methods of evaluating the cardiac risks, you might, if you're in the US, you know about the Framingham risk score. If you live in Europe, they use the SCORE method. There's also the Reynolds risk score. So there are many out there that we can use. But however, time and time again, all of these risk scores that we use in the general population have underestimated the risk in the RA population. So therefore, the EULAR recommendations came out, and there are a long list of recommendations, but I'm only highlighting one of them, which I found the most interesting, which is looking at this multiplying the risk score. So if they underestimate, what can we do? And they feel that in their consensus statement, if you have 2 out of the 3 qualifications, either RA of longer than 10 years, any extra-articular manifestations, if you're seropositive, then you should multiply your score by 1.5 to get the true risk. So the question is, do clinicians really recognize this risk? And whether or not we have a good algorithm or current medical management that assesses our patients differently than the general population. So I'm going to rapidly go through some of the abstracts that actually looked at this and put some data behind what we are actually doing out in practice. So this is out of UPenn. They wanted to screen the rheumatologist's attitude on cardiovascular risk assessment as well as what they're doing with the lipid panel. So they looked at 24 out of 28 of their rheumatologists that were practicing there. A majority of them, greater than 70%, do not believe that their surrounding network of primary cares were really understanding this awareness, which I thought was larger than I would expect, given that we are also in the general medicine meetings as well. That 67% regularly do counsel their RA patients about cardiovascular disease, and 70% are comfortable in counseling their disease about primary prevention, including diet and exercise. Then they went on further to say, well, who should we treat and screen? So 25% believe that PCP should be the ones that drive this. 75% believe that there should be some sort of shared role where, at certain intervals we should both be asking. And 87% felt that primary care should be responsible for actually then treating. So one is really education awareness, who should screen, and then who should treat. So it's much more complicated, and so maybe that's why there's some hands that go up and not go up, because there's really no definition around what exactly there is to do. And you're not alone, because this is what we find across the U.S. So in terms of actual lipid screening, you could look at the notes that I put in the booklet, but in general, as you can see, there are greater than 25% that never check, and then up to 81% rank it as a risk equivalent to diabetes, finding that is the most useful approach to thinking about how our RA patients are in cardiovascular screening. So we really run the whole spectrum of what we are doing, and so I think it's really important just to know what other people are doing. So basically, we asked, well, what are the barriers to the screening? So time is really, right? So, you're putting patients on new DMARDs, you're teaching them about a new chronic disease, and by the way, you're going to teach them all about primary prevention. So we understand that, patient complexity, and then also forgetting or needing a prompt. So in our busy day, we're not trained normally to be primary prevention cardiologists. And what would be helpful. So many of us who have electronic medical records, there are ways that we can, sort of remind or have a pop-up window. And, maybe there's other ways that people in clinical practice can share today with what they can do to remind us. I've heard many patients feel that, many physicians feel that maybe the onus falls on the patient. The patient should just be aware, and they should, be asking more questions to their primary care physician. So this study shows that there's some disconnect between your primary care and your rheumatologist, and I just thought that would be an interesting tidbit. So these are some comparative studies looking at also lipid screening. This is out of Canada. So you can read that in your chart, but this was a much larger study looking at 13,000 individuals with RA and controls and trying to compare between this group. This study found that without a history of any previous diabetes or coronary artery disease, that RA patients were screened for lipids about the same rate than the general population. So there are some places in different healthcare systems where screening might be done. This one was looking at lipids screening in Boston, and actually taking a little bit further and looking at cardiovascular outcomes and linking this. This study showed that RA patients that are screened for lipids also that controlling the LDL was associated with reduced outcomes. So this went a little further than just screening, but also matched it with some of their disease activity. The next one's out of New York, also reviewing electronic databases, all around the same theme of what we're doing in screening. And this one I just found interesting because they showed different inflammatory diseases, so not just RA, but looking at PSA, lupus, and gout. And what they found was that patients seem to be more aware of RA screening, so your primary cares and your networks, than some of the other inflammatory diseases. So even though maybe rheumatologists feel that the risk might be equivalent, there is, it seems like in the general physician world, in the primary care, that there might be some bias where RA gets more screening than other diseases. So this is further looking at a German population, same concept, looking at what the cardiovascular risk control is. I just wanted to give you this information. I don't want to go through in detail all of these, but these abstracts I thought highlighted some of the screenings that were done in the US and other parts of the world. So once again, in this particular study, it did show that there was insufficient screening and treatment of hyperlipidemia and hypertension. This is the German cohort. So I think we have a lot of work cut out for us in terms of what we really mean by screening and how we really need to do this, this work. So I know this is a big area, but I just thought it would be nice to kind of go through different abstracts all over the US and the world on how people are screening and what they are doing. So I'm just going to end with this last abstract before we take some Q&A. So because you see that there's so much heterogeneity around the parts of the world looking at this topic, there's been a group called Attack RA that I just wanted to mention. They had an abstract out that are trying to address a more specific cardiovascular screening tool for our patients. So this particular Attack RA group, run by Shireen Gabriel out of the Mayo Clinic, took 5,600 RA patients without any prior disease and specifically went after all different countries, as you can see listed there. And they wanted to follow them for about 6 years. And they're trying to develop a tool that might be a little bit more comprehensive for our patients. So they had 476 RA patients that actually developed a cardiovascular event in this cohort. And they looked at their event rates, and they range from 0.8 to 7.5. They found their lowest rate was in Norway and UK, and their highest rates at US, South Africa, Netherlands, and Sweden. So given this sort of information, there's just a lot of heterogeneity amongst the cardiovascular rates. So therefore, maybe one particular sort of risk calculator might not be as accurate for all of these different parts of the world. And so their group is trying very hard to better understand this heterogeneity and how maybe certain things might be driving the risk factors that will help us be better at risk assessment. So they're looking at a tool that can be used similar to the Framingham, but more tailored for our patients. So I just wanted to let you know that that was some research that was coming out. So I think this is my last slide. Sorry about that, if I could go back one. So this is just summarizing that they found the rates to be very different, which is something that we didn't really appreciate that much before. And it's important that maybe a risk score worldwide can address some of these differences across the country. So I guess Dr. Rigby will come back up with me and we'll take questions for both us. So the question was that in sort of patient, I guess, physician practices that don't practice in a closed system where they don't always know who their primary care cardiologist, you know, they are referred to different areas, and also the territorial issue I hear of, you know, they could possibly be already screened for all of these things, and so why would you screen again within the same year, which is very reasonable. So I think that, you know, that you do need to either there's another abstract that I didn't show that was really interesting that sort of touched to that, where everybody thought it was somebody else's role to do it. So, well, I think the PCP should be doing it and they don't do anymore, or I think, you know, if they have any risk factors, the patient should, you know, take on the responsibility to tell their primary care. And so I think I see that spectrum. But I still think that when we don't have consensus right now within our group, and we know that patients are dying younger of heart disease, that whatever system might work for you to take that extra step, I still think is necessary now until these risk algorithms come up, or when we have better imaging to tell us when somebody's at risk. But, you know, I think at this point we do have some obligation to create some system that might be helpful for you.
So I just want to add, I totally agree with that comment. And even when you want to treat, the literature on when to treat preventatively, primary prevention, is so confusing. And the primary care physicians, even if you flag it, or even if you recommend the patient to start them, oftentimes they say, no, you have not made criteria. So I'm going to ask, where's the data that's going to provide the clarity for rheumatoid arthritis that exists for diabetes? Because if we had that, I don't think anybody would have a problem putting a diabetic on a statin and expect any blowback.
Definitely a moving target. I think that's a really good point. So it's interesting that, you know, our job is to just get them to prevention, especially the high-risk patients, those that don't have a cardiologist or a primary care, who are looking to understand their risk, who are coming in as a smoker, or you know, their BMI is elevated, they have a strong family history. Those kind of common, you know, internal medicine risk factors, you feel obligated to do something, and you might not have the skill set to help them stop smoking, lose weight, you know, check their yearly cholesterol. So it's interesting that even my group in prevention, sits around very confused about this moving target. So as you know, there's new HAA guidelines looking at when you should start, whether the LDL target should be 70 or 100. And so, in secondary prevention, it's very easy. We know that you should be started on an aspirin and a beta blocker if you've had a heart attack. But if you haven't had a heart attack, that's that moving target. And so they take in family history and your risk of prediabetes and then metabolic syndrome, which is, obviously a whole new world, which many of our patients fall into, unfortunately. And so a lot of that is sort of the, what I feel cardiologists have a much better sense than we do, because we, well, I should just speak for myself. I think I go more by these, sort of guidelines and consensus statements. But if you ask me whether or not I really have a lot of, experience on, how to use different cardiovascular imaging to increase that risk or decrease that risk, I don't. And that's what they have. And that's what they're trained to do. So when somebody asked me, well, why prevention? So we found that in our closed system, they were the best equipped when it's a moving target, when to add these other modalities to help them start. And, just because it says to start aspirin, if the patient, needs to be on chronic NSAIDs or have other risk factors or on Coumadin, they're not going to be started on aspirin. These are recommendations. These are not meant to be a recipe cookbook. So I think that's what I found working with them, is that, yes, they use that to see what category, what their risks are, but then the actual treatment, just like when we use DMARDs, it's not just because you have erosions you need to be on this DMARD, it's also their comorbidities, and they do the same thing. Sure, that's a great question. So what does a treatment affect, DMARD effects on cardiovascular mortality rate? So there's many different studies. Jeff Curtis has some large epi studies looking in large databases, looking at both non-biologic DMARDs and biologic DMARDs, and it does sort of make sense that by more aggressively treating or getting a patient to a low disease activity or a remission, that would decrease all of your inflammatory parameters, therefore decrease your risk of subclinical accelerated atherosclerosis. So I think in all of those studies that has shown to be a correlation. But unfortunately, there's a lot of biases that go into these large studies. So, the decision to be placed on a non-biologic DMARD or a biologic DMARD already sort of changes the type of RA patient you are. So looking just solely at that and correlating to events is kind of hard to then make that next step. So what we really need is probably prospectively looking at an RA patient and looking at their time to event. The mechanistic studies are now going towards showing that decreasing your inflammatory risk over time will decrease your risk for many of the comorbidities, including cardiovascular disease. There's some interesting work around lipids that I didn't show today, but the higher your disease activity, the more dysfunctional your HDL is. So not just the level, but how your body reacts with these molecules. So.
I would like to embellish with that about the BEST trial that was presented at ACR. And so the BEST trial, as every rheumatologist knows, it's 4 limbs and it's treat to target. And it's not a huge study, but it was like 560 or 600 patients. And they reported this year on cardiovascular outcomes in the BEST trial. And basically found that regardless of which you started, methotrexate, combination, Cobra, that cardiovascular events went away, and their epidemiologic statistics were is that at the long-term follow-up of the BEST trial for going on now for X number of years, that the event rate for cardiovascular endpoints was not different than the general population. I mean, that's one study just saying if you treat the target, you're doing exactly what you're discussing. So I think it was one of the most provocative abstracts at the meeting. Do you have any comments on that?
I think one of the knocks on their data was the fact that there was to get in the trial, you couldn't have poorly controlled diabetes or pre-existing conditions. So it wasn't, so we'll have to wait to see how what their control group is.
You know, there's also the secular trends now, you know, because the way that we treat an RA patient now compared to how we were 10 years ago is so different, right? Because these people that are getting in, they're getting care. They're coming to see you for that clinical trial every whatever month.
Yeah.
And so there's been a lot of, you know, look at that. So like you said, it's not generalizable.
Right. We don't know.